Hi, my name is Wana Najwa binti Wan Hazizi and I am with my partner Nurul Shazwani binti Mahade. We will present about urinary system renal cell carcinoma. Okay, for our presentation today, we will begin with a brief introduction to renal cell carcinoma. Okay, next we will discuss the etiology and complication of RCC. After that, we will focus on the imaging modalities and followed by radiological appearance on ultrasound, CT scan and MRI. After that, we will explain the technical consideration for each modality and conclude with the most appropriate imaging modality for RCC. Okay, next we go to introduction. What is renal cell carcinoma? Renal cell carcinoma is commonly known as RCC. It is the most common primary malignancy of the kidney, accounting for more than 85% of renal tumors. Among the subtypes, clear cell RCC is the most frequently encountered. It's followed by papillary RCC. One important clinical feature of RCC is that it is often referred to as a silent tumor because early stage RCC usually does not produce noticeable symptoms. Due to this, many cases are detected incidentally during imaging examination performed for unrelated reasons, such as abdominal pain or routine health screening. Okay, next is etiology. The etiology of renal cell carcinoma is multifactorial, which arises from a combination of genetic, environmental, and lifestyle factors. Sporadic RCC is more common, but hereditary conditions such as von Hippel-Lindau disease significantly increase the risk of developing RCC at a younger age. Other well-established risk factors include advanced age, male, gender, and lifestyle factors such as smoking, obesity, and hypertension. Radiation exposure has also been identified as a contributing factors in the development of RCC. Okay, next we go to complication. Renal cell carcinoma is known for its tendency to metastasize early, especially through hematogenous spread. The most common sites of metastasis include the lung, lymph nodes, bones, and liver. In addition to metastasis, RCC may cause paraneoplastic syndromes, which occur due to hormone-like substance produced by tumor. For example, include hypercalcemia, polycythemia, and nephrotic syndrome, all of which can complicate patient management and worsen prognosis.
Hi, my name is Nurul Shazwani binti Mahade, and now I will explain about the next subtopic, which is imaging modalities. So in this subtopic, I will explain the modalities that is usually used in assessing RCC, which is the ultrasound, computed tomography or CT, and magnetic resonance imaging or MRI. So these modalities play an important role in the use of RCC investigation for early diagnosis and treatment planning. And each modality highlight different pathological and anatomical aspect of the disease. Okay, the first modalities is ultrasound, which is the commonly used in renal masses evaluation, and it is the initial investigation of choice since it's safe, readily available, and inexpensive to perform, and it has the ability to differentiate between solid and cystic renal masses. Now we have the newer technique, which is contrast enhanced ultrasound, that offering a better characterization of the renal tumor compared to the traditional grayscale ultrasound. And in this contrast enhanced ultrasound, we introduce the contrast agent to the patient that are neither hepatotoxic or nephrotoxic, and no ionizing radiation. And this is really great benefit to the patient with kidney problem or disease who cannot receive contrast agent. However, ultrasound is inferior in characterizing renal masses compared to others imaging modalities such as CT and MRI. And ultrasound is dependent on the apparatus scale. Next, we have computed tomography or CT, that is superior accuracy compared to the ultrasound, and it also have a similar diagnostic performance with MRI, but it is much more readily available and with a rapid acquisition of time. And we have CT renal protocol, which allow for better evaluation for the renal tumor that involving 4 phase, which is the first phase is pre-contrast, where in this phase the image detect hemorrhage, calcification and fat, and also provide a baseline for comparison to the post-contrast image. And then we have corticomodulatory phase, which is shortly after the injection of the contrast media, where in this phase particularly differentiate the RCC from the other subtypes. Okay, next we have nephrogenic phase, where in this phase it's provide a uniform enhancement of the renal parenchyma. And finally, we have the excretory phase, where we can visualize the contrast within the collecting system. And CT also helps in determination of cystic renal masses using the Bosniak classification, where we measure the lesion attenuation in Hounsfield units. And lastly, we have magnetic resonance imaging or MRI, which is this modality is indicated to those patients who is unable to undergo CT scan that may be due to allergic to iodinated CT contrast and pregnant patient without renal failure. MRI provide more accuracy in renal masses assessment, where it poses a superior soft tissue contrast and then reduce sensitivity to the calcification and no pseudo enhancements. But MRI have a certain limitation where it takes a longer scanning time and then cause a motion artifact, and then it limits to the patient with claustrophobics and also a patient with metallic implants. In this image, we can clearly see a huge heterogeneous mass that is pointed by the red arrow there, where the mass is irregular and ill-defined margin, which is often reflecting a mixture of solid tissue, fluid, hemorrhage, or necrosis. And this appearance is more suggestive of malignancy. Next, this image is the color Doppler signal of ultrasound that is show internal vascularity within the mass, meaning that there's a presence of blood flow inside the lesion. So this abnormal vascular pattern suggests a solid hypervascular tumor rather than a simple cyst. And this is commonly seen in renal cell carcinoma. And this one is another appearance of RCC in the contrast enhanced ultrasound, where in this image show a cystic renal lesion that appear as irregular thickening of the internal septum. Then we move to the image appearances of renal cell carcinoma in CT scan. So in this image, we can see the first one is the non-contrast image, where we can see there is a mass, renal masses, a solid renal masses on the right kidney with high intensity, which is appear like dense masses there, concerning for malignancy. And then after the contrast injection in the arterial phase, we can see the strongly enhanced of the mass from the 33 Hounsfield unit to the 85 Hounsfield unit. And then the attenuation decrease, representing contrast washout on the late phase. We move on to the next image. As we can see here, the first image, we can see an isodense calcified lesion, where isodense here means the calcification has similar intensity with the soft tissue. And then we have the arterial phase, where it shows inhomogeneous enhancement, which is uniform enhancements of the lesion. And then the contrast agents from the lesion fades earlier than normal renal cortex, producing earlier hypoenhancement during the venous phase. And this early washout pattern is characterizing image feature of the renal cell carcinoma. So why it's the washout pattern happens? Because the tumor is very vascular, so it fills quickly with the contrast, but it can hold the contrast, so the enhancements drop on the late image. Now we move on to the MRI image. So in this image show a coronal plane of T2 weighted image that show a heterogeneous mass located at the lower part of the kidney, where the white arrow pointed there. And then the mass appear hyper intense or brighter in the middle of the tumor due to the necrosis. And we also can see a signal of dark halo, or the border of the lesion around the lesion is dark. Okay, next one is the shifting chemical shift image, which compares in phase and opposed phase in T1 image. So if a tumor contains fat, the signal cancel on opposed phase, so causing a signal drop. And then this tell us the lesion has intratumoral fat. And the last one here is a coronal subtract dynamic contrast enhanced, where the white arrow there pointed a strong enhancement and heterogeneous renal tumor that consistent with a hypovascular malignancy.
Okay, back to me again. Now I will present about technical consideration. So it is include ultrasound, CT scan and MRI for RCC. Okay, now I will present about ultrasound first. For ultrasound, when performing ultrasound for renal mass evaluation, a proper technique setup is essential to obtain diagnostic quality image. A curvilinear probe is commonly used for a general renal overview because it allows adequate penetration, while a high-frequency linear probe between 5 to 10 MHz may be used for superficial lesion or when high spatial resolution is required. Color and power Doppler imaging are important to assess the vascularity of renal masses, as malignant lesions such as RCC often show increased internal blood flow. Image optimization technique, including appropriate adjustment of gain, depth, focus, and harmony imaging, can help lesion contrast and border definition. However, ultrasound is highly operator dependent and image quality may be reduced in obese patients or in the presence of bowel gas, which can limit its diagnostic accuracy. Okay, next we go to CT scan. For CT imaging, adherence to a multiphasic renal CT protocol is crucial for accurate assessment of renal cell carcinoma. This protocol typically includes non-contrast corticomedullary, nephrography, and excretory phases, each serving a specific diagnostic purpose. This last acquisition is recommended to improve lesion detection, allow accurate measurement of tumor size, and assist in evaluating local invasion and vascular involvement. Okay, for radiation safety, it is important consideration. Therefore, dose reduction techniques such as the split bolus method may be used to lower radiation exposure while maintaining image quality. The use of iodinated contrast media is essential for evaluating enhancement pattern, but Renal function must be assessed beforehand, especially in patients with pre-existing kidney disease or diabetes. Okay, last for technical consideration, it is magnetic resonance imaging MRI. So MRI offers several technical advantages, particularly its excellent soft tissue contrast and lack of ionizing radiation. Comprehensive MRI protocol includes T1 weighted and T2 weighted sequences for anatomical assessment, diffusion weighted imaging for lesion characterization and detection or recurrence, and dynamic contrast enhanced MRI to evaluate tumor vascularity. Okay, gadolinium-based contrast agent enhance visualization of renal tumor and blood vessel. However, renal function should be evaluated prior to contrast administration to reduce the risk of nephrogenic systemic fibrosis. Okay, motion artifact can significantly degrade image quality, so brief holding techniques and patient cooperation are essential. Despite its advantages, MRI is limited by longer scan time, patient claustrophobia, and contraindication related to metallic implants. So what can we conclude for all of technical consideration is understanding the technical consideration of each modality is essential to ensure accurate diagnosis, optimize image quality, and improve patient safety in the evaluation of renal cell carcinoma.
For the gold standard imaging or the modalities of choice is CT scan, because CT scan has a high sensitivity, high specificity, and overall diagnostic accuracy compared to others modalities. And a study show a sensitivity of the CT scan is greater than 90%, and then the specificity is greater than 30% to 50%, and then the accuracy can reach above the 80%. And then CT scan is also widely available, rapid to perform compared to MRI, even though MRI have a better sensitivity and accuracy, and it's CT also very cost effective for our patient and making it practical and reliable modality for the diagnostic imaging of the renal cell carcinoma. And that's all from us. Thank you so much.